GI anatomy, blood supply. All right, so first and foremost, GI anatomy blood supply is probably the easiest. I know that every single time that I talk about blood supply, it can be a doozy, but this one's not too bad. So it's separated into three structures: the foregut, the midgut, and the hindgut, okay? And that's going to be pretty much encompassing all of our GI organs that you need to know. The foregut is going to be from the lower esophagus all the way to the proximal duodenum. It's going to encompass also the liver, the gallbladder, the pancreas, and the spleen, okay? So everything in the foregut is going to include all of the accessory organs that's found in the GI tract, okay? Then you have the midgut, which is just the distal duodenum to the proximal 2/3 of the transverse colon. And then lastly, we have the hindgut from the distal 1/3 of the transverse colon all the way to the upper portion of the anal canal, right at the end of the pectinate canal, or the pectinate line, all right? So for the foregut, all of those things are supplied by the celiac artery. Then at the midgut, it's all supplied by the SMA, superior mesenteric artery, and then the hindgut is all supplied by the inferior mesenteric artery. And the way that we remember this is CSI, like the TV show on about a detective work. It's celiac, SMA, and then IMA, CSI. Okay. Now, all of these arteries branch right off of the aorta. So the celiac artery comes off the aorta, SMA comes directly off the aorta, and IMA comes directly off the abdominal aorta. And they all branch anteriorly, and they're single. Okay, and this is an important aspect because all arteries supplying the GI tract are single and branch anteriorly, whereas everything else that's non-GI are going to have paired branches that branch laterally and posteriorly. Okay, not that high yield to know, but it's just important information just to see, just so you're able to visualize what's going on. Now, there's some areas known as watershed areas that have dual blood supply. So it doesn't have one specific blood supply, and that causes an increased risk of ischemia in times of hypotension. So patients that are hypotensive, severely hypotensive, and then present with severe ischemic bowel, you're most likely going to see the ischemic bowel at these watershed areas. And those areas are known as 1, the splenic flexure, and 2, the rectosigmoidal junction. So the left upper quadrant and then the left lower quadrant. Okay, so those are the areas in which you're going to be seeing some of the pain due to increased risk for ischemia in patients that are hypoperfused. Okay, and the splenic flexure, the reason behind it is because both the SMA and the IMA share blood supply there. And then for the rectosigmoidal junction, the IMA branches, and you're going to start to share some blood supply with the superior rectal artery. All right, so keep in mind those two watershed areas for patients that are hyperperfusing, that have hypotension, and then later on present with ischemic bowel. So there's two kind of pathologies associated with these main arteries. One's known as nutcracker syndrome and the other is superior mesenteric artery syndrome. They're very straightforward. The nutcracker syndrome is just compression of the left renal vein between the superior mesenteric artery, the SMA, and the aorta. Okay, so let's think about it this way. If you were to take a look at the anatomy of the body, the left renal vein, okay, has to cross over in order to dump into our IVC. And in order to do that, it's crossing over the aorta and it goes under, okay, posterior to the SMA, but anterior to the abdominal aorta. And that, at times, compression can occur, all right? And it can lead to abdominal pain, flank pain, gross hematuria, and then left-sided varicocele is highly, highly associated with it because, remember, our left gonadal vein drains into our left renal vein, and so then you could see left-sided varicocele due to this nutcracker syndrome, okay? So all it is just the left renal vein being compressed by the SMA and the aorta. Now, for the superior mesenteric artery syndrome, or SMA syndrome, it's very similar pathology, but what happens is that the SMA and the aorta smash on the transverse portion of the duodenum, okay, or the third portion of the duodenum, and it leads to essentially a bowel obstruction. And you're probably going to see this in patients that have rapid weight loss, all right? So that's another kind of common pathology associated with the SMA and the aorta. So SMA and the aorta, if the SMA moves posteriorly towards the aorta, it can smash the left renal vein, causing nutcracker syndrome, hence the left-sided varicocele. That's why they named it nutcracker. And then the SMA syndrome, it could also cause by, smashing and causing a duodenal obstruction. All right. Now, back to our foregut, midgut, and hindgut. So the foregut is supplied by the celiac artery, okay, and that's from the esophagus to the first portion of the duodenum. And the branches of the celiac artery, or the branches of the foregut, right, are very, very high yield for you to know. So for the celiac artery, there's 3 branches that are very high yield. The number 1 first branch is left gastric branch, okay? Number 2 is the splenic branch, and number 3 is the gastroduodenal, which comes off of the common hepatic, Okay, so there's three branches off the celiac artery, or the celiac trunk, I should say. The first one's left gastric, second one's splenic, third one is common hepatic. And then from the common hepatic, the highest yield one to know is the gastroduodenal. Okay, so I want to kind of paint a picture of what's going on. And each one of these are going to supply different portions. That's important to know, okay? And they have important pathologies associated with them. So the first pathology that you should know is, well, let's just start with the left gastric. Okay, so the left gastric artery is going to supply our distal esophagus, as well as half of the portion of your the lesser curvature of the stomach. Okay, that's going to be the left gastric, and it's going to go towards the stomach, right? The left portion of the stomach. That's really like all you kind of need to know about the left gastric artery. If you see like some type of perforated ulcer that's like a gastric ulcer, then it's most likely bleeding from the left gastric artery. So a perforated gastric ulcer is most common in the lesser curvature of the stomach, and it's going to be bleeding from the left gastric artery. All right. Now, kind of in comparison to that, for the duodenum, if you have a duodenal perforated ulcer, on the posterior side, it's most likely going to be bleeding from the gastroduodenal artery, right? And that's the branch off of the common hepatic, okay? And so that's its high yield pathological association, all right? So if you have a perforated posterior duodenal ulcer, it's going to mainly be bleeding from the gastroduodenal artery. The blood's going to be coming from the gastroduodenal artery, okay? If you have bleeding on the lesser curvature of the stomach, that's a gastric ulcer, the bleeding is most likely going to be coming from the left gastric artery, okay? Now, lastly, we have the splenic artery. The splenic artery is going to give rise to the short gastric, okay, which is the short gastrics are the only blood supply to the fundus of the stomach. So if there's some type of fundal necrosis or fundal abnormalities that's not receiving any blood, then you know that it's a problem with the splenic artery. So if the splenic artery occludes, the short gastrics lose blood and then the fundus becomes ischemic, okay? So it's the only area of the stomach without dual blood supply. It's just the spleen, okay, the splenic artery. All right. Now, a couple other things that they want you to know about the spleen is, one, it's supplied by the foregut, right? Because the splenic artery comes off that celiac trunk, but it's not derived from the foregut. Okay. The spleen is derived from the mesoderm. Okay. So that is a key feature that they like to test on. It's just a memorization thing. In my opinion, stupid. Who cares? But the embryologists love it. So that's the first thing they want you to know about the spleen. The second thing they want you to know about the spleen is that the spleen is the most commonly injured abdominal organ. Okay, the most commonly injured abdominal organ is going to be the spleen. All right, so that's the second thing that they like you to know about the spleen. So just a quick run-through overview one more time. You have the celiac artery or celiac trunk that supplies the foregut, and the foregut goes from the distal esophagus all the way down to the first portion of, or to essentially the proximal duodenum, right? And it includes all of the accessory organs like the liver, the gallbladder, the pancreas, and the spleen. Then you have the midgut, which is from the distal duodenum all the way to the proximal 2/3 of the transverse colon, and that's supplied by the SMA. And then finally, the hindgut, supplied by the IMA, is from the distal 1/3 of the transverse colon all the way to the pectinate line of the upper portion of the anal canal. All right. Now, branches of the celiac trunk, you have three main branches. Is going to be the left gastric, the splenic, and the common hepatic. Off of the common hepatic, the main one you need to know is gastroduodenal. The gastroduodenal is going to be affected in pathologies such as duodenal ulcer perforations. If you have duodenal ulcer bleeding, the blood's going to be coming from the gastroduodenal artery, okay? Mainly going to be the posterior portion of the duodenum. If you have a perforated ulcer at the gastric site, at the small or the lesser curvature of the stomach, the bleeding is mainly going to be from the left gastric artery, okay? And then lastly, if there's some type of occlusion in the splenic artery, you can have fundal necrosis and hypoperfusion because it's the only area of the stomach in which the splenic artery is the sole blood supply. All right, so keep that all in mind. I know it can be somewhat confusing, but truthfully, I promise you, once you kind of understand it all, the blood supply to the GI tract is very, very easy. So now, finish talking about arteries, we got to talk about the kind of the portal system and how that works. So before we discuss the portal system, I have to discuss with you just like the anatomy in which everything exists, okay? So what happens is all of the blood that is collected from the GI tract must be sent to the portal system first to be cleaned by the liver. And then once the liver cleans the blood, it sends it into the systemic system, okay? And the reason behind that is, once again, the human body is a perfect machine, okay? It realizes that human beings not only take in nutrients, but they can also take in toxins that are toxic to the human body. So why, as it collects the nutrients through the blood, why would it send all that nutrients and toxins and just dump them right into the system, right into the systemic system without it being cleaned first. Hence, one of the main functions of the liver. Okay, so what happens is the foregut, the midgut, and the hindgut, okay, as they're supplied by those specific arteries, the celiac artery, the SMA, and the IMA, they have the same veins where the blood is draining into. Okay, so all of those foregut, midgut, and hindgut have the same named veins. So that you have the celiac vein, you have the superior mesenteric vein, and the inferior mesenteric vein. All right, and so all of that blood that's being drained back into those veins is going to collect nutrients, which is good for us, right? And it's also going to collect all of the bad stuff as well. Okay, it's going to collect all the toxins, like if you drink alcohol or if you take a lot of Tylenol. All right, and in our gut is already, it's producing a lot of, there's a lot of bacteria within our gut. It's considered outside, right? That's why whenever we have a perforation in our GI tract, it's scary because it can lead to immediate sepsis, right? Because that's essentially outside being dumped into your body. Okay, it's just garbage, it's gunk, it's bacteria. So they produce some toxins as well. That's bad for the human body. So all of that, it drains into their respective veins, the celiac vein, the SMV, and the IMV, and then those all meet up, all those branches meet up and pour into the portal vein. The portal vein then goes through the liver, which cleans the blood through the portal vein, okay? And then all that blood gets dumped essentially into the hepatic vein, which is the systemic system, and then that could be dumped into the IVC, all right? So that's kind of what's going on from a larger picture view. Okay, now there could be some pathologies associated with the portal system, a lot of pathologies associated with the portal system that's high yield for you to know. Okay, so anything that can cause portal hypertension can cause a backup in this system that I just described. Okay, and we'll discuss the causes of the portal hypertension. One of them main causes that you're going to see is like liver failure or cirrhosis, where the liver doesn't function as well for cleaning the blood, so the blood moves through it slower. And so that causes portal hypertension and it causes blood to back up into all of those veins that we just discussed. And it backs up into the branches of those veins, right? So the celiac vein, it's going to back up into like the left gastric vein, right? So keep in mind, all those branches still exist, but instead of arteries, they're veins, okay? So let's begin with the first one. The first pathology very associated with it is esophageal varices. Okay, so anything that causes portal hypertension, remember the main cause that you're going to see is going to be liver cirrhosis or liver failure, which we'll talk about later on, the pathologies, but just remember anything that causes portal hypertension, okay? Now, what happens is, in esophageal varices, you have portal hypertension, so all the blood that's being poured into the portal vein, it's going to get backed up, right? And it's a closed system, so it's going to back up into the celiac vein, and the celiac vein is going to back up into the left gastric vein, right? Because remember, it's named very similar to the arteries. So let's think about the arteries. The arteries are the celiac artery, and the branches of the celiac artery is going to be 1, the left gastric artery, right? We already discussed this. 2, it's going to be the splenic artery. And 3, the common hepatic artery, right? So the same thing occurs. Now you have the left gastric artery is going to have backup of blood flow because the portal vein has hypertension. It's going to back up into the celiac vein, and now it's backing up into the left gastric vein. Well, what do we know about the left gastric vein? Or I should say, what do we know about the left gastric artery? Well, the left gastric artery supplies blood to the distal esophagus, right? So if you have the distal esophagus providing blood by the left gastric artery, that means the blood from the distal esophagus that's going to be drained is going to be drained into the left gastric vein, okay? They named it very well. It's very easy, okay? So that happens when we have that buildup in the backup of blood. You're going to see esophageal varices, which is just blood building up into the left gastric vein, okay? All right, very, very important. Now, what you'll see, and this is a pathology later on that you'll notice, but once again, it's very highly associated with liver cirrhosis and patients that have liver failure, is if you do an endoscopy, you will literally be able to visualize just like the bulging of the left gastric vein into the esophagus. And what happens is that bulging of the veins could rupture. Those veins can rupture, okay? If the hypertension is too bad and the backup is too bad, and they could rupture and you could bleed out internally. All that blood can start to just rupture into your esophagus, and you could start vomiting red blood, and all that blood is just going to be bleeding into your GI tract, okay? And you could bleed out. So that's why esophageal varices is so scary. But we'll talk about that pathology later. I just want you to understand the anatomy of it right now, okay? Another location in which this portal vein backup is going to be seen is at the umbilicus, and this is known as caput medusae, all right? Caput medusae is essentially the same thing, but the portal vein is going to back up into the para-umbilical vein, a part of the portal system, all right? And then the last one is you could have rectal varices or anorectal varices, and this is where the portal system backs up into the superior rectal vein, all right? So what they say is the varices of the gut, the butt, and the caput, all right, which is caput medusa. And that is commonly seen with portal hypertension, all right? Now, what they want you to know also is the treatment. So if all else fails, you could treat these patients with a TIPS procedure, transjugular intrahepatic portosystemic shunt, okay? And all this is, and I remember getting a specific question on this, for a TIPS procedure, what they do is that they will actually make a connection between the portal vein and the hepatic vein, all right? And they will bypass the liver, because in patients that have liver cirrhosis, that's the main problem. That's what's causing the portal hypertension. So they will just connect the portal vein to the hepatic vein. And so that means all the blood coming from the GI tract is going to drain just directly into the systemic system. Okay, so from the portal vein directly into the hepatic vein, directly into the IVC, back to the heart. Okay, now, what did I tell you? This is a big issue because you're bypassing the liver. Why is it a big issue? Because the toxins cannot be cleared from the liver. And so you can have, and by the way, your GI tract, which makes, there's a bunch of bacteria in it, makes a ton of ammonia, all right? Specifically when we eat protein, it makes a ton of ammonia. And that ammonia is toxic to our brain and the rest of our organs. And so patients with TIPS procedure have a huge increased risk of developing hepatic encephalopathy, okay? Very important to know that, and we'll talk about hepatic encephalopathy and what that truly means later on. But I want you to understand the anatomy of it all right? So that's the portosystemic anastomosis. That's the portal system. So one more time, I'm going to walk you through all of the arteries and what happens, and then the veins, the portal system, and then back to the systemic system. All right. So first, from the abdominal aorta, you have 3 anterior branching arteries in order from top to bottom, and supplied for the foregut, midgut, and hindgut, respectively. You have the celiac trunk, the SMA, and the IMA. The celiac trunk has 3 main branches that you need to know, okay? The first branch is going to be the left gastric artery. The second branch is going to be the splenic artery. And the third branch is going to be the common hepatic artery. Common hepatic artery has one main branch you need to know, which is the gastroduodenal artery, okay? Now, at the left gastric artery supplies the proximal portion of the lesser curvature of the stomach, as well as the distal portion of the esophagus, okay? And all that blood from the left gastric artery is going to drain into the left gastric vein, all right? Next, we have the splenic artery. The splenic artery is going to supply the short gastric vessels, which supply the fundus of the stomach, all right? Last, we have the common hepatic artery, which gives blood to the gastroduodenal artery, and you will see this and bleeds from the duodenal ulcers, okay? Now, as we said, for the left gastric artery, it's going to drain blood into the left gastric vein, and the left gastric vein, along with all the other branches from the celiac artery, they're all going to drain back into the celiac vein, okay? Along with all the other branches from the midgut are going to drain into the SMV, superior mesenteric vein. And all the other branches from the hindgut are going to drain into the IMV, or the inferior mesenteric vein. And they all drain in together. The celiac vein, the SMV, and the IMV are going to drain into the portal vein, which gets cleaned by the liver, and then it sends its blood into the hepatic vein, which is sent into the systemic system via the IVC, okay? I hope this makes logical sense anatomy-wise. Lastly, we're going to talk about the pectinate line, but that's going to be for a separate video. I want you to understand the portal system and the arteries and the blood supply.